Hello, my name is Brooke Thornburg, and I am a PharmD candidate here at Purdue University. Today I'm going to be discussing semaglutide eligibility in hospitalized patients prescribed high-intensity statins. So here's a brief overview of what I'll be discussing today: the introduction, methods and data collection, results, and conclusion. A recent study called the SELECT trial has established the efficacy of semaglutide in reducing the incidence of death from cardiovascular causes in overweight patients without diabetes. This study was conducted at Bart's Trust in London, England, which is a network of 5 hospitals and is home to the largest cardiovascular center in the UK and also leads in stroke units. In May of 2026, the National Institute for Health and Care Excellence published their technology appraisal guidance. This established prescribing criteria for hospitals. So what we need to know is how many people are going to be eligible and how much will it cost the trust across the 5 hospitals. The aim of this study is to evaluate patient eligibility across the trust to provide an estimate for logistic and financial analysis. So who is eligible for semaglutide for cardiovascular risk reduction? NICE establishes criteria as anyone with a BMI over 27 and established cardiovascular disease, which they define as any one of the following: a myocardial infarction, stroke, or peripheral artery disease. So looking at the data set, data was pulled from all patients across the trust that were prescribed a high-intensity statin during hospital admission between May 2025 and May 2026. We chose high-intensity statins to narrow our population to people with established CVD. Since high-intensity statins are indicated for secondary prevention in CVD, theoretically, any eligible patient will have been prescribed a high-intensity statin. And this data set came up with 16,446 patients. And you can see the breakdown by which statin. So atorvastatin 80 had 9,950, atorvastatin 40 had 6,005 patients, and rosuvastatin 20 milligrams was only about 500 patients. So the data that we did collect from these patients included the date of administration, weight, BMI, site of admission, GLP-1 prescription history, and A1C. Unfortunately, high-intensity statin use does not confirm patient eligibility for semaglutide. Patients might be on a statin and have CVD that doesn't fall into the eligibility criteria. Others might not have CVD at all and take it for primary prevention. Because of this, additional data must be collected. So before we collected this additional data, we needed to narrow down the data set. So first, we removed anybody that was ineligible based off of weight. So we only included patients with a BMI over 27 that were on a high-intensity statin. And this reduced our data set by about 44%, but still left us with 9,000 patients. So to narrow it even further, we tried to identify patients with CVD by choosing atorvastatin 80 milligrams, which is the first-line statin option for secondary prevention. This is still around 5,000 patients, and to get it down to a more reasonable number, we just looked at 1 week of patients over a 7-day time frame from May 21st through May 27th of 2026 across the trust, and that gave us around 190 patients. Utilizing patient charts and medical records, each person was assessed for semaglutide eligibility based on cardiovascular history. We also collected some additional data to assess semaglutide eligibility for alternative indications, being obesity or type 2 diabetes. All patients with a BMI over 27 and established diagnosis of an MI, stroke, or peripheral artery disease were deemed eligible per NICE criteria. And then patients receiving a new diagnosis of MI, stroke, or PAD during this admission with no prior history were deemed newly eligible. Looking at the results of 190 patients, 116 met the eligibility criteria for semaglutide. That's 61%. Of the eligible patients, 42 were newly eligible upon their admission that week of the 21st of May. That's 36%. And then breaking down the eligibility by hospital, St. Bart's had the most patients with 41%. Royal London had 27%, followed by Whipps Cross with 17%, and Newham with 13%. But the proportion of newly eligible by site was a bit different. St. Bart's had 73% of newly eligible patients, with Royal London having 14%, then Newham with 7%, and Whipps Cross with only 4%. Roughly extrapolating this data over 52 weeks anticipates 6,000 eligible patients across the trust annually. Of those, 2,000 patients would be newly eligible. St. Bart's Hospital alone would see 2,500 eligible patients, 1,600 being newly eligible. A couple things to consider: of the 116 eligible patients, some may fit the criteria to be prescribed semaglutide for other indications. So 70% were potentially eligible for semaglutide for weight loss due to a BMI over 35. And about 50% of patients may meet eligibility criteria for semaglutide for diabetes. Additionally, 4% of the patients had a current prescription for a GLP-1 medication during their admission. 4 of those patients were for diabetes, 1 being for weight loss. Of note, 4 patients did pass away during their admission. The results of this project demonstrate a significant number of patients meet the eligibility criteria for semaglutide for risk reduction of cardiovascular disease. Across the trust, St. Bart's Hospital will likely see the most eligible patients, of which a significant amount are estimated to be newly eligible. So what are the next steps? Use the extrapolation estimates to anticipate the yearly cost of semaglutide across the trust. Establish protocols for prescribing and monitoring semaglutide within the trust, and developing a counseling checklist for pharmacists, and provide education and training regarding the administration of semaglutide. And here are my sources. And then I would like to give a special thanks to St. Bartholomew's Hospital and my mentor, Dr. Shellhouse, for their resources and expertise in aiding my project. And thank you.